Bismillahirrahmanirrahim. On to the second session of our question bank series. So, the question number 5 of internal medicine, they are asking about a 26 years old woman who comes to the emergency department due to 2 weeks of the fever and water diarrhea, uh, abdominal cramps, and weight loss of 4.5 kg. She has a history of AIDS and is non-compliant with therapy. The patient has been admitted to the hospital twice in the last 4 months due to pneumonia. Temperature is 38.2 degrees Celsius, that is high. Pressure is 102 by 62 millimeters of mercury, and pulse is 102 per minute. BMI is 18 kg per meter square. Scattered lymphadenopathy is present in the cervical, axillary, and inguinal chains. Abdominal examination reveals mild, diffuse tenderness and no organomegaly. CD4 count is 18 per millimeter cube, that is very low, and alkaline phosphatase is 484 units per liter. The blood culture is specialized. In specialized media grows non-tuberculous mycobacteria. Which of the following is the most appropriate antibiotic therapy for this patient? And the answer is option C, that is macrolide based combination therapy. The educational objective of this question is stating that Mycobacterium avium complex is seen primarily in the patient with an advanced AIDS, that is CD4 count of less than 50 per millimeter cube. It is caused by the non-tuberculous mycobacterium, Mycobacterium avium or Mycobacterium intracellular. Patients usually have non-specific symptoms like diarrhea and weight loss and an elevated alkaline phosphatase level and lymphadenopathy. Diagnosis is typically made with a blood culture or bone marrow aspirate. Treatment with a macrolide-based combination therapy is curative, but antiretroviral therapy should be initiated to prevent the future infections. Coming back to our discussion, so Mycobacterium avium complex epidemiology. Mycobacterium avium and intracellular, and the patient is with advanced AIDS and CD4 count of less than 50 per millimeter cube. Manifestations include fever, weight loss, abdominal pain and diarrhea, LAD, and often hepatosplenomegaly and increased alkaline phosphatase. LAD means lymphadenopathy. Then we have diagnosis, that is blood lymph node culture will lead to the growth of non-tuberculous mycobacteria. Treatment is with macrolide with ethambutol. Primary prophylaxis is with azithromycin and wait a minute. Treatment is macrolide and ethambutol. Primary prophylaxis with azithromycin is no longer recommended. The patient with untreated AIDS have subacute fever, weight loss, gastrointestinal symptoms, and positive blood cultures of non-tuberculous mycobacterium indicating non-tuberculous mycobacterium indicating the disseminated Mycobacterium avium intracellular complex. So this manifestation is very important. A patient of AIDS with subacute fever, weight loss, gastrointestinal symptoms, and positive blood culture for non-TB mycobacteria. MAG is caused by the ubiquitous non-tuberculous Mycobacterium avium and Mycobacterium intracellular. Patients with AIDS who have CD4 count of less than 50 per millimeter cube are at greatest risk. Manifestations include non-specific systemic symptoms like fever, cough, abdominal pain, diarrhea, night sweats, and weight loss. Lymphadenopathy and an elevated alkaline phosphatase level, reflecting the hepatic involvement. Okay. Hepatosplenomegaly can also occur. The MAC or Mycobacterium avium intracellular complex is diagnosed with the blood cultures or bone marrow aspirate. First line treatment includes a macrolide, for example clarithromycin or azithromycin combined with the ethambutol. Antiretroviral therapy should also be initiated a few days after the MAC therapy begins. In the past, patients with untreated AIDS who had CD4 count of less than 50 per millimeter cube were given primary prophylaxis, that is with azithromycin, to prevent the MAC infections, but it is no longer recommended due to its cost, low overall risk, and concern of antimicrobial resistance. The choice A, that is dapsone based combination therapy. So this was not the option of choice because trimethoprim dapsone is an alternative treatment for the pneumocystis pneumonia, PCP. Although this patient is at high risk for PCP due to the lack of antimicrobial prophylaxis, most patients present with progressive respiratory distress, hypoxia, dry cough, and fever. Blood culture would not grow non-tuberculous mycobacterium, and alkaline phosphatase elevation and diarrhea would be atypical. The choice B, that was isoniazid combination therapy. This was not the option of choice because the isoniazid based combination therapy is mainstay of Mycobacterium tuberculosis treatment. Although patients with AIDS are at much greater risk for infection, disseminated disease, the presence of circulating non-tuberculous mycobacteria indicates MAC. rather than Mycobacterium tuberculosis. The choice D, that was stating metronidazole based combination therapy. So this was not the option of choice because metronidazole based combination therapy is used to treat amoeba histolytica infections. Although patients with AIDS are at increased risk for invasive amoebiasis and many causes present with the abdominal pain, fever, diarrhea and weight loss, the presence of non-tuberculous mycobacteria in the bloodstream makes MAC far more likely. The choice E, that was pyrimethamine based combination therapy. This was not the option of choice because the pyrimethamine based combination therapy is used to treat toxoplasmosis, which usually causes encephalitis in the patients with the AIDS. Although pulmonary and gastrointestinal infections can occasionally occur, the non-tuberculous mycobacterium would not be seen on the blood culture. In question number 66, they are asking about a 66 years old man who is admitted to the hospital for left lower quadrant abdominal pain, fever and vomiting. The CT scan of the abdomen reveals diverticulitis. The patient is started on the supportive care and antibiotics. His symptoms improve over 2 days. However, on the third day of hospitalization, he reports acute pain in the right angle, acute pain in the right angle which becomes unbearable within a few hours. The patient had a similar pain 1 year ago that resolved with over-the-counter medications. The medical history is notable for type 2 diabetes, hypertension. Okay, so there is type 2 diabetes, hyperlipidemia, hypertension. His temperature is high, like 37.1 degrees Celsius. Blood pressure is also high, 140 by 90 millimeters of mercury. Pulse is also very high, that is 98 per minute. The BMI is so high, 36 kg per meter square. Examination shows a swollen erythematous right ankle with moderate restriction of movement due to pain. Left ankle is normal. Both the ankles were normal at the time of admission to the hospital. Which of the following is the most likely diagnosis? And among the options, the answer of choice is option B, that is gout. The educational objective of this question is stating that gout typically presents with an acute monoarticular arthritis. Acute monoarticular arthritis that quickly progresses to maximum intensity within 12 to 24 hours. Triggers include alcohol use, surgery or maybe trauma, dehydration and certain medications, for example diuretics. So the discussion of this question is stating that the risk factor for the gout are increased risk with medications like diuretics and low dose aspirin. The surgery, trauma or recent hospitalization, maybe volume depletion, diet which include high protein foods like meat and seafood, high fat foods, fructose or sweetened beverages, heavy alcohol consumption, underlying medical condition, for example hypertension, obesity, chronic kidney disease and organ transplant. The decreased risk is seen with the dairy products intake, vitamin C more than equal to 1500 milligrams per day and coffee intake that is more than equal to 6 cups per day. This patient with acute rapidly progressive ankle pain, a prior history of similar pain has acute gout. Although it is most common in the first metatarsophalangeal joint, gout can also involve the knee and ankle. Gout is characterized by recurrent attacks that typically develop overnight or early in the morning, reaching maximum intensity within 12 to 24 hours. The definitive diagnosis is obtained via synovial fluid analysis showing the inflammatory cells and needle-shaped negatively birefringent urate crystals. So you must always remember that there will be negatively birefringent urate crystals. A gout attack can be precipitated by the conditions that cause increased production or decreased elimination of uric acid. Okay, so increased production or decreased elimination of uric acid or an acute change in the uric acid levels. Common triggers include heavy alcohol consumption, intake of urate-rich food, trauma or surgery, dehydration and medication that raises, for example, that raises what? That raises the that raises like thiazide diuretics and cyclosporins or lowers, for example, allopurinol, uric acid levels. The choice A and E, that is enteropathic arthritis or psoriatic arthritis, both of them were not the option of choice. Why? Because the spondyloarthropathies, for example, ankylosing spondylitis, psoriatic arthritis, reactive arthritis, and enteropathic arthritis, which is associated with the inflammatory bowel disease, predominantly affect the axial skeleton. These disorders can cause acute peripheral oligoarthritis, but it is typically less dramatic than the gout. Most patients will have additional symptoms including the low back pain and stiffness and inflammation of the tendon insertions, that is called as enthesitis, the inflammation of the tendon insertion. Then the choice C, that was neuropathic joint. It is not the option of choice because the neuropathic or Charcot arthropathy causes destructive arthritis in the patient with a long-standing diabetes who have peripheral neuropathy. Although ankle is commonly involved, obvious deformities can cause and chronic pain are characteristic. Obvious deformities and chronic pain are characteristic. The choice D, that is osteoarthritis. It was not the option of choice because osteoarthritis is most often causes chronic pain involving the knee, hips, hands, acute inflammatory flare-ups. Knees, hips, hands. Acute inflammatory flare-ups are unusual in the absence of precipitating factors like heavy overuse of joint. The choice F, that is rheumatoid arthritis. It was not the option of choice because the rheumatoid arthritis can cause chronic inflammatory arthritis, most commonly affecting the metacarpophalangeal joints. Finding includes stiffness and doughy swelling of the joints rather than acute erythema and effusion. And choice G, that is septic arthritis. It was not the option of choice because septic arthritis is characterized by acute monoarticular arthritis, often with fever than chills. Onset occurs over days, not hours, and as in this patient, although often caused by hematogenous seeding from a concurrent infection. Septic arthritis is more commonly due to the gram-positive organisms rather than the gram-negative and anaerobes implicated in diverticulitis. Question number 7. In question number 7, they are asking about a 55 years old man comes to the emergency department due to a 2 days of fever, chills, and productive cough. Over the past 4 months, he has had 2 episodes of pneumonia, both of which resolved completely with antibiotics. He smoked a pack of cigarettes per day for 30 years, but quit following the second bout of pneumonia. The patient's only other medical problem is hypertension. Temperature is 38.9 degrees Celsius, that is high. Blood pressure is 130 by 86 millimeters of mercury and pulse is 98 per minute. The respirations are 18 per minute. Oxygen saturation is 94% on the room air. Crackles are increased and increased breath sounds are present over the right lower lung field. Leukocyte count is 14,200 per millimeter cube, so there is a profound leukocytosis, and blood urine nitrogen is 12 mg per deciliter. Chest X-ray reveals lower lobe consolidation. Antibiotics are administered. On follow-up 5 days later, the patient describes improvement in his cough and fever. Crackles are still present at the right lung base. Review of the chest X-ray obtained during the previous episode of pneumonia reveals a consolidation in the right lower lung segment, same as found in the current episode. Which of the following is the most appropriate next step in the management of the patient? And the answer among these options is option Charlie, that is CT scan of the chest. The educational objective of this question is stating that lung malignancy is a potential cause of localized airway obstruction and may present with an episode of recurrent pneumonia. CT scan of the chest should be used to evaluate the patient in whom there is suspicion of the lung malignancy. The table is stating that causes of recurrent pneumonia involving the same lung region, local airway obstruction like extrinsic bronchial compression, for example by the neoplasm or the adenopathy, intrinsic bronchial constriction like bronchiectasis and foreign body. Recurrent aspirations region may vary depending upon the position, seizures, alcohol or drug use, and GERD and dysphagia. Involving different regions of the lung, it can be because of immunodeficiency like HIV, leukemia, or combined variable immunodeficiency. Sinopulmonary disease, for example cystic fibrosis and immotile cilia. Non-infectious, for example vasculitis and BOOP, that is bronchiolitis obliterans with organizing pneumonia. The explanation is stating that the patient with the recent fever, chills, productive cough and leukocytosis has had his third episode of right lower lobe pneumonia in the past several months. Recurrent pneumonia occurring in the same anatomic location of the lung raises suspicion for localized airway obstruction, which if present can lead to impaired bacterial clearance and predisposition to infection, for example post-obstructive pneumonia. Potential causes of localized airway obstruction include number 1, external bronchial compression due to the lymphadenopathy, expanding neoplasm or vascular anomaly, internal bronchial obstruction due to foreign body, bronchiectasis, bronchiostenosis, or rarely the endobrachial carcinoid. Smoking is strongest risk factor for the development of primary lung malignancy. In this patient, age more than 50 with a significant smoking history of 30 pack year and evidence of localized airway obstruction, it is essential to evaluate for lung malignancy using a CT scan of the chest. The choice A, that was barium swallow study. It was not the option of choice. Why so? because a barium swallow study may be used to evaluate for the gastroesophageal reflux disease or dysphagia leading to the chronic aspiration, which is potential cause of recurrent pneumonia. However, CT scan of the chest is most appropriate next step in the patient with a suspected lung mass. The choice B, that is bronchoscopy. So bronchoscopy is not the option of choice because CT scan of the chest typically precedes the bronchoscopy in the patient with a suspected lung mass. Bronchoscopy is often used to obtain a tissue biopsy with a centrally located lung mass is identified. Uh, Bronchoscopy is often used to obtain a tissue biopsy when a centrally located lung mass is identified on the CT scan. Choice D, that is repeat chest X-ray in 6 weeks. So this was not the option of choice because in patients more than 50 years of age, repeat chest X-ray to assess the malignancy is generally recommended between 6 and 12 weeks following a single episode of pneumonia. However, in this patient with a significant smoking history and evidence of localized airway obstruction, for example, the recurrent pneumonia, warrants more immediate evaluation. CT scan of the chest has better sensitivity than the chest X-ray for detecting the lung malignancy, especially in the presence of alveolar infiltrate. The choice E was not the option of choice, that was serum quantitative immunoglobulin assessment. It was not the option of choice because serum quantitative immunoglobulin levels are needed to diagnose the common variable immunodeficiency, which typically presents in the adulthood with recurrent infections of the lung and upper respiratory tract, for example, sinusitis and otitis media. However, immunodeficiency like CVID would be expected to cause the recurrent pneumonia in different regions of the lung rather than the same region. The next question is question number 8. They are asking about a 45 years old man who comes to the office due to a 2-month history of painless, non-pruritic purple lesion on his leg. He has also had progressive fatigue, weakness, and fleeting joint pain in his knees and elbows for the past several months. The patient has had no fever, weight loss, diarrhea, or abdominal pain. Okay. Temperature is 37.36.7 degrees Celsius, that is high. Blood pressure is 147.91 millimeters of mercury, and pulse is also 84 per minute. Cardiac examination reveals no murmurs or additional sounds. There are multiple purpuric, palpable lesions on both lower extremities that do not blanch with the pressure. Laboratory studies are as follows: hematocrit is 39%, platelet count is 160,000, leukocytes count is 3,000. All of them are non-significant; they are within the reference ranges. Serum creatinine level is high, 1.9 mg per deciliter. AST is 78 and ALT or alanine aminotransferase is 99. Both of them are kind of high. C3 complement level is low normal. C4 level is very low. Then we have rheumatoid factor that is positive. Anti-nuclear antibody is negative and HIV antibody is also negative. Your analysis shows 3 plus blood and 3 plus protein and few dysmorphic red blood cells. Which of the following is the most helpful in establishing the patient's diagnosis? And the answer for this question is option F, that is viral hepatitis serology. Educational objective of this question is mixed cryoglobulinemia syndrome in an immune complex deposition disorder commonly associated with a chronic hepatitis C. It presents with a fatigue, palpable purpura, arthralgias, renal disease, and peripheral neuropathies. Laboratory studies show serum cryoglobulins, hypocomplementemia, positive rheumatoid factor, elevated transaminases, and kidney injury. The table is stating that cryoglobulinemia, disease association type 1. Type 1 cryoglobulinemia is associated with a lymphoproliferative or hematologic, for example, multiple myeloma. The clinical findings in type 1 cryoglobulinemia is that it may be asymptomatic, or maybe there is hyperviscosity, that is blurry vision, thrombosis, for example, Raynaud phenomenon, and in skin we can find livido reticularis in purpura, which we are finding in this particular patient. Then we have complement levels, they will be normal. Over here we can see in type 2 and 3 cryoglobulinemia, chronic hepatitis C or HIV, lupus, systemic lupus erythematosus, they can be the cause. Systemic fatigue, arthralgias, but the symptoms of the type 2 and type 3 cryoglobulinemia will be systemic symptoms include fatigue and arthralgias. The renal symptoms include glomerulonephritis, hypertension. Pulmonary symptoms include dyspnea, pleurisy, and skin include palpable purpura. I'm sorry, it was not livido reticularis that we are seeing. I guess it is palpable purpura, which we can see in this patient. What is LCV? LCV means leukocytoclastic vasculitis. And then complement levels will be low C4. So it is basically type 2 or type 3 cryoglobulinemia that we are seeing in this patient. This patient presentation is the patient's presentation is concerning for mixed cryoglobulinemia syndrome (MCS), which is caused by the immune complex deposition in small to medium sized blood vessels, leading to endothelial injury and organ damage. It commonly presents with a fatigue, non-blanching palpable purpura, arthralgias, renal disease, for example, hematuria, proteinuria, and glomerulonephritis, and peripheral neuropathies. Renal involvement is variable, but most common manifestation is hypertension. Liver involvement, for example, elevated transaminases is common. Patients rarely may have central nervous system or pulmonary involvements. The MCS or mixed cryoglobulinemia syndrome is most commonly associated with a chronic inflammatory condition such as hepatitis C virus infection and systemic lupus erythematosus. Consequently, every patient suspected for having MCS or should be tested for HCV, hepatitis B virus, and HIV. HCV associated mixed cryoglobulinemia syndrome immune complexes are formed from HCV, anti-HCV IgG, IgM anti-IgG antibodies, rheumatoid factor, and complement. The diagnosis of MCS can be confirmed serologically, serum cryoglobulins, low complement levels, or with a skin or renal biopsy. Treatment involves addressing the underlying disease and can also include plasmapheresis and immunosuppression, for example, glucocorticoids and rituximab for the patients with rapidly progressive or life-threatening courses. The choice A, that is ADAMTS13 activity. So this was not the option of choice because thrombotic thrombocytopenic purpura decreased ADAMTS13 activity can present with fever, microangiopathic hemolytic anemia, thrombocytopenia with non-palpable rather than palpable purpura, kidney injury, and neurologic findings, for example, confusion and stroke. So there is a pentad of ADAMTS13. Compared to the MCS, thrombotic thrombocytopenic purpura is associated with much more severe anemia, thrombocytopenia, median hematocrit 25% and platelets less than 20,000 per millimeter cube, and it is not associated with hypocomplementemia. The choice B, that is anti-cardiolipin antibody testing. So it was not the option of choice because antiphospholipid antibody syndrome can be due to a number of antibodies including anti-cardiolipin antibodies. This patient has no history of recurrent and arterial or venous thrombosis, for example, deep vein thrombosis and stroke. The choice C and D, which were bone marrow biopsy and serum protein electrophoresis, both of them were not the option of choice because the bone marrow biopsy and serum protein electrophoresis are more helpful in establishing the underlying cause of type 1 cryoglobulinemia, which is commonly due to the lymphoproliferative or hematologic disorders like multiple myeloma. Type 1 cryoglobulinemia usually presents with the normal complement levels, negative rheumatoid factor, and symptoms of hyperviscosity or thrombosis like Raynaud phenomena, digital ischemia, and blurry vision. The choice E, that is over here, that is urine toxicology screen. It was not the option of choice because the cocaine can cause significant vasoconstriction and acute kidney injury due to the glomerular hypoperfusion. However, cocaine is not usually associated with a palpable purpura, rheumatoid factor, or low complement levels. So we will keep this session till here and will continue from question number 9 in the next session. Until then, Allah Hafiz, fi manila, and take care.